and New Yorker writer Atul Gawande. It's a collection of essays on how surgical mistakes happen and the human element that makes saving lives possible. This talk from Politics and Prose Bookstore in Washington, D.C. is just under an hour.
One of the owners of Politics and Prose Bookstore, and I'm really happy to welcome you here tonight. I'm sorry, I'll have to move this down. I'm happy to welcome you here tonight. As I was telling Atul Gawande, my father was a physician, and he was interested in health policy, as he was in the public health service during the Second World War, and then he remained tremendously interested in healthcare for the indigent, healthcare for the elderly, and national health policy in general. And I found out something that I didn't know, which is Atul Gawande shares a lot of those interests that he worked during the Clinton campaign and in the early part of the Clinton administration on healthcare policy, both during the campaign and at HHS. So I feel that even though I didn't know that there's a certain way in which concerns about healthcare and health policy imbue this series of essays, and that although the subject is somewhat the education of a young resident and his observations on what he's learning and what he's seeing as a physician, as a young physician, that it's placed in a larger context than one would expect. And I think that we are really indebted for the way in which Atul Gawande has translated some of the more technical, everyday concerns of a physician into language that we lay people can understand. And I know that all of us wish that more physicians could do that. Thank you very much for coming tonight.
Thank you. Well, thank you, everybody, for coming out, and it's a special event for me to be here in Washington. My wife is from Alexandria, Virginia, and over many years I've had a lot of time spent down here. And then I did have the special opportunity now, almost embarrassingly 10 years ago, to work in the Clinton administration on healthcare policy and spend a wonderful more than year and a half, and also at times difficult time during that period. Well, I went on to medical school and my medical training and into surgery of all things. And about 4 years ago, I found myself in the odd and wonderful position of getting to write occasional essays about medicine and science for the New Yorker magazine. About 2 years into it, I was approached by a publisher with the very flattering idea of trying to put together my ideas about how medicine worked together for a book. And I said, of course, why, I'd love to. And now this, I'm both nervous and proud to say, is the result. I'm, as I mentioned, still a young doctor, a surgical resident, nearing the end of my 8 years in training in surgery. And this book arises out of the intensity of that experience. I've come to think of medicine as a strange and remarkable and also sometimes disturbing business, and writing became my way of thinking through what it is that we actually do. We have arrived, in a sense, at a new and important and also uncertain juncture in medicine. On the one hand, medicine has become extraordinarily complex and bewildering and also powerful, capable of extending people's lives and making people's lives better, whether they have heart attacks or cancer or depression. On the other hand, the notion that doctors are gods is long gone. And people are now expected to take medical decisions into their own hands in many cases, make decisions for themselves and not simply do what your doctor tells you to do. Yet no one, I think, has really prepared anyone for this, whether doctors or patients. No one, I think, in particular, has shown people how it is that medicine really works, what decisions matter, how decisions are made, how much uncertainty there is, and how that uncertainty is dealt with. And so what I tried to set out to do in writing this book is try to show exactly that, show how things go right, how things go wrong, and why. And in the process, tell a few stories, I hoped. I think the thing that struck me most upon entering the field of medicine is how fundamentally human an endeavor it turned out to be. When we hear about medicine today, when the media writes about medicine, what we hear about is the massive amount of knowledge and the new technologies and all this amazing ability of 21st century medicine. But what we experience, what we find when we get in close, is a much messier, more fragile reality of an individual doctor and an individual patient trying to sort through it all. You have a belly pain, and it's the amazing know-how and the medicines and the technology and clear answers that you want. But what do you get? It's just a doctor, someone with bad hair and a little annoying laugh and a weak chin and some things they know and some things that they don't. We all want medicine to be, I think, an orderly field of knowledge and procedure, but it isn't. Some of this can be helped, and some of it can't. There are then, I think, 3 reasons that things in medicine don't always turn out the way that we expect them to, or that we imagine that they're supposed to. 3 layers, in a sense, to the distance between theory and practice. And these 3 layers make up, well, very cleverly, I should add, the 3 sections of my book. So first, and perhaps most upsetting, as a cause for imperfection in medicine, is fallibility. And in the chapters in this section, I consider everything from, as someone described earlier, the dilemmas of the learning curve and needing to practice upon people in learning what we do, to mistakes and how they occur, to how well a profession like ours deals with problem individuals. All of these, I think, are worries that patients certainly have. And they're also things that I don't think we in medicine have explained or even necessarily understood particularly well. A core element, and I think the hardest to grasp element, is that it's good doctors, not bad doctors, who are the ones who make the bulk of the mistakes. And trying to think through what that means for all of us is part of what I had been trying to do, especially in the stories in this section. The second section, and the second reason behind the imperfection of medicine, is about how much mystery still remains in the human condition, how much of medical science still remains terra incognita. And so in one chapter, I consider not rare problems, but very common problems, like the troubles of a patient with a chronic pain. It was one of those patients with a terrible back pain. He was on disability. He had been an architect and had had an injury from which things only got worse and worse. And yet, when x-rays were done and MRIs were done, nothing structurally wrong with his back could be found. A very common situation, precisely the situation for many people with disabling back pain. It's actually the situation that makes many of us in medicine want to run away when one of these patients come to the clinic, because we feel like we have so little to necessarily offer. And what I want to understand was why, what it is we know, what it is we don't know, and how it is we deal with how much we don't know. In another chapter, I examine the story of a woman with an intractable case of nausea and vomiting that progressed to the point that she would even begin to bleed from her own stomach, that no doctor could either explain or treat. There are more chapters considering what may be a kind of weird range of problems from, for example, the story of a 450-pound man with worsening obesity who decided to undergo radical surgery to allow him to stop him from eating altogether. Another about a newscaster who sought medical help because she blushed so severely that she could not, she lost her job as a newscaster. I think the striking thing is that we act and even do major operations despite at times rather unclear evidence about what precisely to do. And it's not surprising that that these situations would end up being a real struggle for doctors and for patients. I think it's also not surprising that the results can be less than we want or expect them to be, and that surprises can happen along the way. The third, and I think critical and also inherent element in medicine is uncertainty. Even if we eliminated the errors, and even if the science of human afflictions were completely understood, there is still an inevitable uncertainty in what we do, in whether the diagnosis you've made is correct, in whether the treatment you've chosen will really turn out to do everything that you hope it will. And I think it's this uncertainty that makes perfection unachievable and also makes medicine so hard. And so in this section, I try to think about uncertainty from a number of angles. I look at autopsy findings where still even to this day, 40% of autopsies will turn up a misdiagnosis. And yet we have, on the other hand, a decline in autopsies. We have a case in another story of a mother accused of murdering her 8 children, although physicians had first thought they were victims of sudden infant death syndrome. And in the final 2 chapters, there are several cases where I hope we begin to see how doctors and patients together sort out how to make decisions in the face of uncertainty, and how sometimes people do it well and sometimes not so well. Coming here today, I was thinking about what I would read to you, and I think what I'd like to read to you about is to pick up one of the threads running through the book that might help show the direction the book goes. And the thread is really a puzzle. It's the puzzle of how medicine can be as deeply uncertain as it is at times, and as plagued by human fallibilities, but at the same time so successful. So I was going to take the beginning of the very last chapter in the book, called The Case of the Red Leg.
Could you speak just a bit louder?
Sure. Seeing patients with one of the surgery professors in his clinic one afternoon, I was struck by how often he had to answer his patients' questions, "I do not know." These are 4 little words a doctor tends to be reluctant to utter. We're supposed to have the answers. We want to have the answers. But there was not a single person he did not have to say those 4 little words to that day. There was the patient who had come in 2 weeks after an abdominal hernia repair. "What's this pain I feel next to the wound?" she had said. There was the patient 1 month after a gastric bypass operation. "Why haven't I lost weight yet?" There was the patient with a large pancreatic cancer. "Can you get it out?" And to all, the attending gave the same reply, "I do not know." A doctor still must have a plan, though. So to the hernia patient he said, "Come back in a week and let's see how the pain's doing." To the gastric bypass patient, "It'll be all right," and asked her to come back in a month. To the cancer patient, "We can try to get it out." And although another surgeon thought he shouldn't, given the tumor's appearance on a scan, operation would be futile and risky, the colleague had said, and he himself thought the odds of success were slim at best, he and the patient, who was only in her 40s, with still young children at home, decided to go ahead. The core predicament of medicine, the thing that makes being a patient so wrenching, being a doctor so difficult, and being a part of a society that pays the bills they run up so vexing, is uncertainty. With all that we know nowadays about people and diseases and how to diagnose and treat them, it can be hard to see this, hard to grasp how deeply the uncertainty runs. As a doctor, you come to find, however, that the struggle in caring for people is more often with what you do not know than with what you do. Medicine's ground state is uncertainty, and wisdom for both patients and doctors is defined by how one copes with it. There is, I think, in a sense, a science to managing uncertainty. Experience matters for one thing, and I mentioned the learning curve. But also, just as important, is simply being systematic about what we do. So let me take another chapter. Consider a relatively simple surgical procedure, a hernia repair, which I learned to do as a first-year surgical resident. A hernia is a weakening of the abdominal wall, usually in the groin, that allows the abdomen's contents to bulge through. In most hospitals, fixing it, pushing the bulge back in and repairing the abdominal wall, takes about 90 minutes and might cost upward of $4,000. In anywhere from 10 to 15% of the cases, the operation eventually fails and the hernia returns. There is, however, a small medical center outside Toronto, known as the Shouldice Hospital, where none of these statistics apply. At Shouldice, hernia operations often take from 30 to 45 minutes. Their recurrence rate is an astonishing 1%, and the cost of an operation is about half of what it is elsewhere. There's probably no better place in the world to get a hernia repaired. What's the secret of that clinic's success? The short answer is that the dozen surgeons at Shouldice do hernia operations and nothing else. Each surgeon repairs between 600 and 800 hernias a year, more than most surgeons do in a lifetime. In this particular field, Shouldice's staff is better trained and has more experience than anyone else. But there's another way to formulate the reason for its success, which is that all the repetition changes the way they think. As Lucian Leap, a Harvard pediatric surgeon who has made a study of medical error, explains, a defining trait of experts is they move more and more problem solving into an automatic mode. With repetition, a lot of mental functioning becomes automatic and effortless, as when you drive a car to work. Novel situations, however, usually require conscious thought and workaround solutions which are slower to develop, more difficult to execute, and more prone to error. A surgeon for whom most situations have automatic solutions has a significant advantage. The Shouldice example then suggests that perhaps physicians should be trained, if anything, to act mostly like machines. One chilly Monday morning, I put on a green cotton scrub top and pants, a disposable mask, and a paper cap, and wandered among the cases in the Shouldice Hospital's 5 operating rooms. To describe one case is to describe them all. I watched 3 surgeons operate on 6 patients, and none deviated even a step from their standard protocol. In a tiled box-like operating room, I peered over the shoulder of Richard Sang, a 51-year-old surgeon with a dry wit and youthful appearance. Though we chatted during the entire operation, Dr. Sang performed each step without pause, almost absently, with the assistant knowing precisely which tissues to retract, and the nurse handing over exactly the right instruments. Instructions were completely unnecessary. The patient, a pleasant, surprisingly composed man of about 35, who occasionally piped up from under the drapes to ask how things were going, lay on the table with his lower abdomen exposed and painted yellow with a bactericidal iodine solution. A plum-sized bulge was visible to the left side of the hard bone of the pubis. Dr. Sang injected the skin with a local anesthetic in a diagonal line from the top of the man's left hip to the pubis, along the crease of the groin. With a number 10 blade, he made a 4-inch slash along this line in a single downstroke, revealing yellow, glistening fat below. The assistant laid a cloth along each side of the wound to absorb the mild bleeding and pulled it open. Sang swiftly cut down through the outer muscle layer of the abdominal wall, exposing the spermatic cord, a 1/2-inch cable of blood and spermatic vessels. The patient's bulge, we could see now, came through a weakness in the muscle wall beneath the cord, which is a common sight. Sang slowed down for a moment, checking meticulously for another hernia, along the area where the cord came through the inner abdominal wall. Sure enough, he found a small second hernia there, one that if it had been missed, would almost certainly have caused a recurrence. He then sliced open the remaining muscle layers beneath the cord so that the abdominal wall was completely open and pushed the bulging abdominal contents back inside. If you have a tear in a couch cushion with stuffing coming through, you can put a patch on the cushion or you can sew it back together. At my hospital, we usually push the hernia back in, place a piece of sturdy plastic-like mesh on top, and sew it to the surrounding tissue. It provides a reliable reinforcement, and the technique is easy to perform, but Sang, like the other Shouldice surgeons I asked, scoffed at the idea. They viewed the mesh as a hazard for infection, since it's a foreign body, expensive, since the mesh can cost hundreds of dollars, and unnecessary, since they get enviable results without it. So as Sang and I talked about such alternatives, he sewed the wall back together in 3 separate muscle layers using fine wire, making sure that the edge of each layer overlapped like a double-breasted suit. After Sang closed the patient's skin with small clips and removed the drapes, the patient swung his legs over the edge of the table, stood up, and walked out of the room. The procedure had taken just half an hour. Many surgeons elsewhere use Schuldeis's distinctive repair method, but obtain ordinary rates of recurrence. It's not the technique that makes Schuldeis great. The doctors at Schuldeis deliver hernia repairs the way Intel makes chips. They like to call themselves a focused factory. Even the hospital building is specially designed for hernia patients. Their rooms have no phones, no televisions, and their meals are served in a downstairs dining hall. As a result, the patients have no choice but to get up and walk around, thereby preventing problems associated with inactivity, such as pneumonia or leg clots. After Sang left the patient with a nurse, he found the next patient and walked him straight back into the same operating room. Hardly 3 minutes had passed, but the room was already clean. Fresh sheets and new instruments were already laid out. And so the next case began. I asked Burns Schuldeis, a son of the clinic's founder and a hernia surgeon himself, whether he ever got bored doing hernias all day long. I would. No, he said, in a Spock-like voice. Perfection is the excitement. Paradoxically, this kind of super specialization raises the question of whether the best medical care requires fully trained doctors. None of the 3 surgeons I watched operate at the Schuldeis Hospital would even have been in a position to conduct their own procedures in a typical American hospital, for none had completed general surgery training. Sang was a former family physician. Bernd Schuldeis had come straight from medical school with no training, no residency at all. And the surgeon-in-chief was an obstetrician. Yet after apprenticing for a year, they were the best hernia surgeons in the world. The lesson, there are many lessons to me about the Schuldeis, but part of the lesson is certainly not only that experience matters, but that being systematic about what we do, about really thinking about what it is we do each day. But even when all of that has been accounted for, even if you've made a protocol out of everything and an algorithm for every problem, there is still a place for and a role for intuition. And I thought I'd read another passage that tries to explain what I mean. Starts out with a bit of a philosophical discussion. In a 1976 essay, the philosophers Samuel Gorovitz and Alistair McIntyre explored the nature of fallibility. Why would a meteorologist, say, fail to correctly predict where a hurricane was going to make landfall? They saw 3 possible reasons. One was ignorance. Perhaps science affords only a limited understanding of how hurricanes behave. A second reason was ineptitude. The knowledge is available, but the weatherman may fail to apply it correctly. Both of these are surmountable sources of error. We believe that science will overcome ignorance and that training and technology will overcome ineptitude. The third possible cause of error the philosophers posited, however, was an insurmountable kind, one they termed necessary fallibility. There may be some kinds of knowledge that science and technology will never deliver, Gorovitz and McIntyre argued. When we ask science to move beyond explaining how things, say hurricanes, generally behave, to predicting exactly how a particular thing, say Thursday's storm off the South Carolina coast, will behave, we may be asking it to do more than it can. No hurricane is quite like any other hurricane. Although all hurricanes follow predictable laws of behavior, each one is continuously shaped by myriad uncontrollable, accidental factors in the environment. To say precisely how one specific hurricane will behave would require a complete understanding of the world in all its particulars. In other words, omniscience. It's not that it's impossible to predict anything. Plenty of things are completely predictable. Gorovitz and McIntyre give the example of a random ice cube in a fire. Ice cubes are so simple and so alike that you can predict with complete assurance that an ice cube will melt. But when it comes to inferring exactly what is going on in a particular person, well, are people more like ice cubes or more like hurricanes? Right now, at about midnight, I'm seeing a patient in the emergency room. Obviously not right now. And I want to say she is an ice cube. That is, I believe I can understand what's going on with her, that I can discern all her relevant properties. I believe I can help her. Charlotte Duveen, as we'll call her, is 49 years old, and for 2 days, she has had an abdominal pain. I begin observing her from the moment I walk through the curtains into her room. She is sitting cross-legged in the chair next to her stretcher and greets me with a cheerful, tobacco-beaten voice. She does not look sick. No clutching the belly, no gasping for words. Her color is good, neither flushed nor pale. Her shoulder-length brown hair has been brushed, her red lipstick neatly applied. She tells me the pain started out crampy, like a gas pain, but then during the course of the day, it became sharp and focused, and as she says this, she points to a spot in the lower right portion of her abdomen. She has developed diarrhea. She constantly feels as if she has to urinate. She doesn't have a fever. She is not nauseated. Actually, she is hungry. She tells me that she ate a hot dog at Fenway Park 2 days ago and visited the exotic birds at the zoo a few days before that, and she asks if either might have anything to do with this. She has 2 grown children. Her last period was 3 months ago. She smokes half a pack a day. She used to use heroin once, but says she's clean now. She once had hepatitis. She has never had surgery. I feel her abdomen. It could be anything, I think. Food poisoning, a virus, appendicitis, a urinary tract infection, an ovarian cyst, a pregnancy. Her abdomen is soft without distension, and there is an area of particular tenderness in the lower right quadrant. When I press there, I feel her muscles harden reflexively beneath my fingers. On the pelvic exam, her ovaries feel normal. I order some lab tests. Her white blood cell count comes back elevated. Her urinalysis is normal. A pregnancy test is negative. I order an abdominal CT scan. I am sure I can figure out what's wrong with her, but if you think about it, that's a curious faith. I have never seen this woman before in my life, and yet I presume that she is like the others I've examined. Is it true? None of my other patients, admittedly, were 49-year-old women who had had hepatitis and a drug habit, had recently been to the zoo and eaten a Fenway Frank, and had come in with 2 days of mild lower right quadrant pain. Yet I still believe. Every day, we take people to surgery and open their abdomens, and broadly speaking, we know what we will find. Not eels, or tiny chattering machines, or a pool of blue liquid, but coils of bowel, a liver to one side, a stomach to the other, a bladder down below. There are, of course, differences, an adhesion in one patient, an infection in another, but we have cataloged and sorted them by the thousands, making a statistical profile of mankind. I am leaning towards appendicitis. The pain is in the right place. The timing of her symptoms, her exam, and her white blood cell count all fit with what I've seen before. She's hungry, however. She's walking around. She's not looking sick, and this seems unusual. I go to the radiology reading room and stand in the dark, looking over the radiologist's shoulder at the images of Duveen's abdomen flashing up on the monitor. He points to the appendix, worm-like, thick, surrounded by gray, streaky fat. It's appendicitis, he says confidently. I call the attending surgeon on duty and tell him what we've found. All right, book the OR, he says. We're going to do an appendectomy. This one is as sure as we get. Yet I've worked on similar cases in which we opened the patient up and found a normal appendix. From what I've learned looking inside people, I've decided human beings are somewhere between a hurricane and an ice cube. In some respects, permanently mysterious, but in others, with enough science and careful probing, entirely scrutable. It would be as foolish to think we have reached the limits of human knowledge as it is to think we could ever know everything. There is still room enough to get better, to ask questions, to learn from knowing when our simple certainties are wrong. I'll go ahead and stop there.
I forgot in my introduction to say what a tremendous writer, a really extraordinary gift. If anybody wants to come and sit on the floor in front, you are most welcome. I see a number of you back there that might be more comfortable on the floor. there's a lot of room up here. So if you can get it down and up, you can sit on the floor. No, come all the way up, Catherine. No, you shouldn't sit in the aisle. No. There's more room in front. Ed, your wife's over here. I also want to ask you to use the mic in the center of the room. We have a mic. It'll be better for our audience on C-SPAN, and it will be better for those of us who are sitting here, and it will take less time if Atul doesn't have to repeat the questions. So make your way to the mic, if you please. And then, first question.
Okay.
Yes, terrific.
Can you hear me?
I can indeed.
Okay. I'm an internist. I work for the Army at Fort Belvoir. I wonder, now that you've had 7 odd years in practice, if you had to do the Clinton plan all over again, leaving aside the 2,300 pages and the 450 decision gates, but the substance of the plan, how would you change it? Or would you change? Or do you think it was okay as it was?
I think the substance of. Thank you for the question. So the substance of the plan amounted to a couple basic principles. We would cover everybody, and we would see to it that the costs would be within a range so the public could have some say over that. And that fundamental reality I would not change. I am in many ways indifferent how we get there. If it means Medicare for everybody, if it means that we keep our private insurance system as it is, but subsidize it so people who don't have it can get it, I'm thrilled. And whatever way it takes to get there, I think is very important. The notion, though, that we still have well over 40 million people who simply do not have coverage for basic aspects of their care, and then another 25 million who have insurance coverage but turns out not to be good enough if they get really sick. I've seen it now after 7 years of being in training, and you see the difference it makes in the care that people get. And it only convinced me more that that is what we need. But it will be a long time in coming still, slow in coming.
Atul, I'm a practitioner in another field, and I have found that pointing out mistakes of fellow practitioners in that field in a public way leads to great problems. And I'm wondering about, in your field, if you are already a member of the American College of Surgeons, have they expelled you yet? And how is it that more surgeons have not come forward to admit their mistakes, of which there are many?
Well, thank you for that question. You know, I wrote this book and have written some of the essays I've written for The New Yorker with some trepidation about how they would be received by my colleagues, by the people who employ me and teach me. And the truth of the matter is I've been shocked at how well it's been received. The American College of Surgeons not only has kept me in their midst, I've been asked twice to speak at their convention, not at all what I expected. And it turns out that that they're grappling with the very same thing that patients are grappling with, which is this new place where doctors are, on the one hand, understood to not be infallible, where patients are expected to take a stronger role in making decisions, and yet very little of it has been well explained to anybody and without a clear sense of how to move forward. And so you have a lot of doctors who are struggling with the fact that we do make mistakes. They may be sued for them. They may be accused of being bad doctors for them, and yet it's still good doctors for whom this is happening. And so there is a struggle to, number one, to understand what is going on. Number two, to be able to explain it to the public and to ourselves in a way that we can all grasp it. And number three, to convey in some way the emotion of that situation. A lot of the mistakes I talk about are my own. And I even now have a hard time sometimes just telling people or reading from those sections of the book. They are very painful, to me sometimes shameful experiences, and yet they are also the experience of every physician, and simply conveying that is also something I think physicians who've spoken to me feel like has been a worthwhile effort. And so I know there are, and I've spoken to many colleagues who disagree with some of the things that I say in this book, but the criticism has been constructive. No one has told me they wish I hadn't written it at all.
Yeah, you were saying before that, yeah, what you were saying before is how human medicine is. And I think that's part of the problem. Now, what happens when I look at medical training, you know, you may have decided at age 6 or 7 or 10 to become a doctor, so you've been focusing, you've been studying all the time in undergrad, everybody was at the parties and you were studying, doing your pre-med bit, you were doing the med school bit. Then finally, after all these years, you go to the hospital, got your little white coat on, and you get to talk to patients. And I see so many of them have no idea how to talk to human beings, you know, right? And what happens is that you know, and I know, that all good doctors got to be good doctors by practicing on poor people. You got to have that volume. You know, you're good Blue Cross Blue Shield, not going to let interns touch them, not going to let students touch them. So now you have a group of medical students who tend to be middle class, upper class, confronted with lower class patients. And they have problems communicating in the first place. You know, so now you have so many people complaining about the doctors really can't talk to them because you've been trained in science all your life. So after being a scientist all this time, now you got to become a human being. Some people make the adjustment and some people can't, you know. And 2 medical questions. One with appendicitis, did you do a rectal exam on her?
Absolutely.
All right. You know, Dr. LaFall always says you got to do that rectal exam. And the woman who had the blushing all the time, did she have mastocytosis?
She did not.
Oh, shit.
I can tell there's a doctor in the midst as well here. Well, you know, at some way, I think we have to be careful about stereotyping doctors in both ways. The physicians I know, the young doctors I know, are all people who actually, from the very beginning, cared about taking care of people, and yet have, yes, struggled with understanding the science. I've been at surgical training for 7 years, and it still astonishes me how much further I have to go till I feel I'm really good at simply the technical part of what we do. And then, yes, then there's the human side of sitting down and talking to people and remembering that these are human beings with individual problems and not just a gallbladder in room 3. And grasping how to begin to communicate with people. It's a retail business in some way, to an extent that surprises you. You know, you're at many levels along the way just someone fitting shoes for people, and understanding that it is a humble position. It is one in which people are bearing themselves to you, and that it is a one person at a time kind of situation is, I think, one of the hardest things to convey to young doctors and also to patients about what is happening. And so you don't want the science divorced from the humanism. You do want people who know that it's a human being at the other end of your stethoscope that you're listening to. I know I don't always meet that goal in taking care of patients. I get angry and tired and flustered, and there are some patients I bond with and other patients I don't. There are undoubtedly differences of class and economics and race that come into that, and it's one of the amazing things about medicine is you meet everybody. It's unlike anything else there is. You know, I think of medicine as the most complex and ambitious endeavor that mankind has ever attempted. It is to take care of every range of potential problem and misery that a human being and human body can undergo, take care of it for every single person in the country, and to do it with the optimal amount of knowledge and compassion that you can possibly bring. It's amazing to me that we come close at all, and of course we don't come short. And yet we do succeed to an extent that still surprises me.
I'm also a physician, a psychiatrist, who has chosen, at least for this point in time,
I think somebody wants you to come a little closer so they can
not
hear you.
to work because of some of my own concerns about the environment in which physicians are practicing currently. And so my question for you is, I'm sure you have read some of the surveys that have been done amongst physicians, looking at their professional satisfaction, some of their loss of morale, and frustration just with the practice of medicine. Part of that, I believe, is attributable, of course, to the changes in medicine and the environment in which we're practicing, the ways in which we no longer have control over the caring environment that we used to have. But in addition, I think what your book is describing in terms of physicians being able to accept their own fallibility and vulnerability is another source of stress. And so these two sources, just in general, could be thought of as external stresses versus internal personal stresses. And based on your experience of 8 years, I graduated about 20 plus years ago. But in 8 years, I'd be curious to know what your read is on the sources of demoralization and poor morale on the part of physicians, whether the sources are primarily internal or primarily external.
Thank you for that question. I, like you, have seen these surveys and understand also the experience of physicians who feel like the pressures of managed care and the insurance environment and the number of patients that you end up having to see nowadays is a source of great unease, takes some of the joy out of doing what we do. I've been struck, though, that many of the surveys from other countries where they don't have those same pressures show the same decline in morale. And what I have come around to thinking is that a lot of this comes from simply the sheer fundamental change in medicine itself. Everywhere, the physician is no longer unquestioned. Everywhere, the physician is no longer necessarily on the pedestal. And also everywhere, the pressures of the fact that our technology makes a huge difference. It does matter what you do for people in a way that it didn't 20 years ago, because we can do so much for different situations. And medicine has become, in a sense, a team sport in a way it never was before. And so now you as a physician have to have a great team of nurses to work with, a team that includes nutritionists and orderlies and visiting nurses at home and administrative chiefs, and a lot of people who you now have to cooperate with and also listen to, and not always have your judgment be the one that matters the most. And it's a world, in a sense, that none of us were well prepared for. So I think the sources are still external to a great degree, because medicine has changed so much, because it's become so much more intense and technological and difficult, because so many patients are in your patient load. A typical internist takes care of, no matter what country you're in, 2 to 3 times as many patients as they used to take care for 10 or 20 years ago. And then you combine that with, as you say, the internal pressures, the reality that mistakes are made, the stakes only grow higher. The more that we can do means there's more we have to get right. And so it compounds that internal sense of fear of failure. And I think being able to think about it, talk about it, explain it, has been my way of coping with a very intense and difficult experience just going through my own training. It's been my way of understanding it and remembering how important and worthwhile it is what we do.
I already had one question, so I'll be quick. This one comes from outside the profession. I was a lawyer before I was a doctor, and we've talked a lot about medical mistakes, which in the real world are known as malpractice. And the shocking thing to me when I went to medical school in my 40s was that it's not just great imponderables. There are some things we'll never understand, but doctors are trained not to look things up. There are no resources in a hospital for them to look up. They're supposed to keep a little book in their The books are made the size to fit in a jacket pocket, and that's all you take with you. You're supposed to remember everything. Doctors feel that they can perform just as well at 4 in the morning if they've been on for 36 hours as they can when they first get there. Everyone in the real world knows that's not true, that there are things that could be fixed. We don't have to wait for mistakes to happen. The airlines don't wait for crashes to figure out what to do to prevent crashes. We say we don't see anything wrong, and therefore we need all this reporting. We don't need reporting. We need common sense.
Thank you. The well, I believe in what you say. The example that I sometimes talk about is the notion that every time I pick up a prescription pad, I feel like I'm an accident waiting to happen. You write 1,000 prescriptions, and you know you're going to get the decimal place in the wrong place some of those times. You know that your handwriting is going to be misread. And what happens when that happens and somebody actually is harmed and dies as a consequence? Well, you get sued, and this is it's the most common mistake that occurs is medication errors. And what have we done for 20, 30, 40 years is we've sued people. And yet all the way along, certainly for the last 10 years, we've had a simple solution that would get rid of 80% of medication errors, and that is to write the prescriptions on a computer. That would get rid of the decimal point errors, that would make them perfectly legible, and yet 99% of physicians, we don't do it. It's partly because of the way that the public looks at our mistakes. It's an individual failure. It's also part of the way that we look at our mistakes. We see it as fundamentally an individual failure, and if we miss the decimal point, we think, God, how could I have been so stupid? Next time, I'm just going to pay more attention, and boy, I'll never make that error again. But we know this is an accident waiting to happen, and yet we still live with an old way of thinking about things. And so it's the lessons, in a sense, of the engineers who have taught anesthesia that, by gosh, why do you make machines where you can turn the oxygen down to 0? Everybody needs some oxygen, so don't even make them that way. Rather than rely on somebody to remember not to turn it down to that. Those lessons are only starting to be learned in medicine. We've only begun to do the research that points the finger at how we do things rather than who does them.
Dr. Gawande, would you tell us why a young medical student would leave New England and move to Little Rock, Arkansas, give up his career and work for the Clinton administration, and also share with us the ups and downs, emotional ups and downs of working during those early years?
So this is Drew Compuris asking the question, who was the doctor I got to know in Little Rock, Arkansas when I moved as a 26-year-old to Little Rock. You know, when I got offered the job to work for Clinton, I'm pretty sure it had something to do with the fact that, number one, President Bush, Sr. then, had 70% favorability ratings coming off the Persian Gulf War, so no one thought Clinton could possibly win. Number two, you got paid next to nothing. And number three, you had to move to Little Rock. And when I got there, folks like Drew Compuris became great friends and took good care of me. What made a 26-year-old do that? My God, you got offered one of the best opportunities you could ever have for someone like me, so it was without question that I jumped ship. I also cared about being involved with the public, being involved with public policy and understanding how it is that we make lives for people better, both inside and outside medicine. The hard part for me has been being back in medical training for such a long stretch. You don't get to think about these things. You're mostly focused on making things go right for one individual person. And writing became my way of being able to step back and think through these things again, and to remember what it is that's important, what it is that we do well, what it is we don't do well, and sometimes to understand a lot of the confusions that occur every day.
I'm wondering what made you so thoughtful and sensitive, and as well as your training.
And that's not my mother.
No, never seen him before in my life. I'm an anthropologist, and actually I wrote a book called The Scalpel's Edge, The Culture of Surgeons, where I followed senior surgeons wherever they went.
I've read your book. It's a wonderful book.
But what I found there was that it was both in the selection of the people who would become surgeons and the training that made them have this penchant for action, this certainty, wanting certainty, and a tremendous discouragement of doubts. And people started out being decent human beings, and there was so much in their training that discouraged this. And I wonder what it is that you went through and what you can recommend in that training.
Well, I should warn you, I mean, you know, I may write very compassionately, but I'm not necessarily that way when I'm with a team of people that I want to make sure everything goes right. The trick of writing has to do with observing as clearly as you possibly can, and you get a lot of that from medicine. But the flip side is that cool detachment doesn't necessarily serve all that well necessarily in the patient arena. And so I try very hard to be as compassionate as I can be, but I know that I'm the same way. You know, part of my fascination with surgery is precisely the surgical persona. It is the person who looks at situations where there is uncertainty and information is unclear and action is necessary, and they take it. You know, that saying, sometimes wrong, never in doubt, that's usually taken as a criticism of surgeons, is precisely what I found fascinating about surgery. It's, in a way, what I wanted is the wisdom to be able to act in the face of uncertainty, in the face of doubt, and to do it with some steel. And you can't do it blindly, and the worst surgeons are ones who have no fear, the ones who go in with no recognition of the doubts that are there. But the best ones are ones who know that their skills are imperfect, that they make mistakes, and yet still go on. And so I think in the end, I'm probably not all that different from a lot of surgeons when you see me on the wards. I think we do need to do a better job of making sure in all of medicine that we don't reduce people to numbers and don't forget that our bluster has to sometimes subside and leave room for patients to understand that we can hold their hand or just sit with them sometimes. But I'm not sure I learned any differently from any of my colleagues. I think of many of my colleagues as better physicians than myself.
I wonder if I could take you back to the issue of how we teach our profession and the whole issue of see one, do one, teach one, and whether you think there might be other alternatives in the the 21st century. If you're a pilot and you fly for American Airlines, and you fly a 757, the first time you fly it for real, you've got passengers on board. And all the training has been done on a simulator. And there are actually huge areas where simulation has real value in the training of physicians and other healthcare practitioners. For example, why on earth would you ever want to learn to do a spinal tap for the first time, or a epidural anesthetic on a mum who's just about to have a baby, and this is your first time round? And I wonder how much you feel we ought to be insisting that we change this ancient profession of ours and adopt some of technology that is there and available for us.
Well, it's the science of learning separates into two parts. The science of there's the learning before doing, and then there's the learning by doing. And you'll never get rid of the learning by doing. There is more we can do when it comes to learning before doing, including simulation, including learning on animals. And this applies not just in the beginning of training, it applies throughout a doctor's entire career. My father is a surgeon in Ohio where I grew up, and he told me that 75% of what he does today, he was not trained to do as a resident. The reality of progress in medicine is that every year there is something new to learn for a doctor. That's part of what makes being a doctor so exciting, is that you're always on a learning curve in what you're doing. And how does he learn to do, a new laser comes out that he can use to break up stones. And how does he learn to do it? Well, he goes up to Columbus, which is about 100 miles from where we live, and up there a company might set up a lab for a day where he gets to practice on an eggshell, tapping with the laser, and then maybe, though not often, they might have a pig for him to try one time on, and then they'll send him home with a video, and then there's got to be the first person that he's got to give it a try on. And that's how learning works. I think it is absolutely imperative and worthwhile that we think harder about how it is we learn, to bring in more learning before doing. But I don't want to soothe people too much by the notion that the learning curve can be eliminated. There will still always be that first time. There will be the 10th time and 15th time, and the curve continues to go on up, so that for all of us, the reality is that that perfection and progress can't occur without practicing on someone, though there is much that we in the medical profession have to take as a lesson to make that part better.
And I would add as a rider to that, you know, how does a surgeon reach a point where he decides he's no longer competent to operate? And the answer is probably because he hurts somebody or kills somebody. If you fly a 747, you get to land it once a year in Chicago in a crosswind of 37 miles an hour and zero visibility, and if you can't do it, somebody marks your book and says, this guy shouldn't fly 747s anymore. And we need the same sort of system to regulate ourselves, and I think this is what your in particular your article, The Learning Curve, has become for us, and I work in medical simulation, and you never mentioned it once, but you've led us well down the path. Thank you.
Thank you. Thank you.
If I understood you correctly, earlier you said that good doctors make more mistakes than bad doctors. Could
No.
you? No.
So I should elaborate on that then.
Oh, good.
So you take the bulk of mistakes that occur, and most of the mistakes by far are done in the hands of good doctors rather than bad doctors. Bad doctors probably are more likely to make mistakes, but by far, most doctors are well trained, are conscientious, and are doing the best job that they can, and at the same time still make mistakes. So the net result is that a lot of mistakes occur. Let me put some numbers on this. We had done a study out of our research group ourselves in 2 states, in Utah and Colorado. We looked at 15,000 hospital patients and looked at all their records and found that reviewing them, 97% had no complications at all. Things went just fine, which is terrific. But 3% had serious complications that involved death or disability or prolonged hospital stays. Half of those complications, according to the physicians who were reviewing the cases, were judged to be avoidable, that is, the result of error. Now, 1% failure rate or error rate is, on the one hand, sounds terrific. On the other hand, when you consider the thousands of people who get medical care, this translates into tens of thousands of people who are harmed avoidably. And the question then is, what can we make of that? What can we do of that? And I think we just have to, the hardest part about the whole thing is grasping that these are not just a handful of doctors that simply need to be thrown out and the problem would go away. Instead, it comes back to those questions like the computer prescription pad that could make such a difference, or the machines that can make such a difference. There are 1,000 steps to taking good care of a patient, even with a simple problem like a pneumonia. And we've only begun to really look at each of those steps and figure out why it is that each of those steps sometimes go awry.
Thank you so very much.
Oh, and thank everybody for coming.
Atul Gawande is a surgical resident in Boston and a staff writer for The New Yorker. Complications, a surgeon's notes on an imperfect science, is published by Metropolitan Books, a division of Henry Holt & Company. Visit henryholt.com.
The troubles of a patient with a chronic pain. It was one of those patients with a terrible back pain. He was on disability. He had been an architect and had had an injury from which things only got worse and worse. And yet, when x-rays were done and MRIs were done, nothing structurally wrong with his back could be found. A very common situation, precisely the situation for many people with disabling back pain. It's actually the situation that makes many of us in medicine want to run away when one of these patients come to the clinic, because we feel like we have so little to necessarily offer. And what I want to understand was why, what it is we know, what it is we don't know, and how it is we deal with how much we don't know. In another chapter, I examine the story of a woman with an intractable case of nausea and vomiting that progressed to the point that she would even begin to bleed from her own stomach, that no doctor could either explain or treat. There are more chapters considering what may be a kind of weird range of problems from, for example, the story of a 450-pound man with worsening obesity who decided to undergo radical surgery to allow him to to stop him from eating altogether. Another about a newscaster who sought medical help because she blushed so severely that she could not, she lost her job as a newscaster. I think the striking thing is that we act and even do major operations despite at times rather unclear evidence about what precisely to do. And it's not surprising that that these situations would end up being a real struggle for doctors and for patients. I think it's also not surprising that the results can be less than we want or expect them to be, and that surprises can happen along the way. The third, and I think critical,
and New Yorker writer Atul Gawande. It's a collection of essays on how surgical mistakes happen and the human element that makes saving lives possible. This talk from Politics and Prose Bookstore in Washington, D.C. is just under an hour.
One of the owners of Politics and Prose Bookstore, and I'm really happy to welcome you here tonight. I'm sorry, I'll have to move this down. I'm happy to welcome you here tonight. As I was telling Atul Gawande, my father was a physician, and he was interested in health policy, as he was in the public health service during the Second World War, and then he remained tremendously interested in health care for the indigent, health care for the elderly, and national health policy in general. And I found out something that I didn't know, which is Atul Gawande shares a lot of those interests that he worked during the Clinton campaign and in the early part of the Clinton administration on health care policy, both during the campaign and at HHS. So I feel that even though I didn't know that there's a certain way in which concerns about health care and health policy imbue this series of essays, and that although the subject is somewhat the education of a young resident and his observations on what he's learning and what he's seeing as a physician, as a young physician, that it's placed in a larger context than one would expect. And I think that we
actually do. We have arrived, in a sense, at a new and important and also uncertain juncture in medicine. On the one hand, medicine has become extraordinarily complex and bewildering and also powerful, capable of extending people's lives and making people's lives better, whether they have heart attacks or cancer or depression. On the other hand, the notion that doctors are gods is long gone. And people are now expected to take medical decisions into their own hands in many cases, make decisions for themselves and not simply do what your doctor tells you to do. Yet no one, I think, has really prepared anyone for this, whether doctors or patients. No one, I think, in particular, has shown people how it is that medicine really works, what decisions matter, how decisions are made, how much uncertainty there is, and how that uncertainty is dealt with. And so what I tried to set out to do in writing this book is try to show exactly that, show how things go right, how things go wrong, and why. And in the process, tell a few stories, I hoped. I think the thing that struck me most upon entering the field of medicine is how fundamentally human an endeavor it turned out to be. When we hear about medicine today, when the media writes about medicine, what we hear about is the massive amount of knowledge and the new technologies and all this amazing ability of 21st century medicine. But what we experience, what we find when we get in close, is a much messier, more fragile reality of an individual doctor and an individual patient trying to sort through it all. You have a belly pain, and it's the amazing know-how and the medicines and the technology and clear answers that you want. But what do you get? It's just a doctor, someone with bad hair and a little annoying laugh and a weak chin and some things they know and some things that they don't. We all want medicine to be, I think, an orderly field of knowledge and procedure, but it isn't. Some of this can be helped, and some of it can't. There are then, I think, 3 reasons that things in medicine don't always turn out the way that we expect them to, or that we imagine that they're supposed to. 3 layers, in a sense, to the distance between theory and practice. And these 3 layers make up, well, very cleverly, I should add, the 3 sections of my book. So first, and perhaps most upsetting, as a cause for imperfection in medicine, is fallibility. And in the chapters in this section, I consider everything from, as someone described earlier, the dilemmas of the learning curve and needing to practice upon people in learning what we do, to mistakes and how they occur, to how well a profession like ours deals with problem individuals. All of these, I think, are worries that patients certainly have. And they're also things that I don't think we in medicine have explained or even necessarily understood particularly well. A core element, and I think the hardest to grasp element, is that it's good doctors, not bad doctors, who are the ones who make the bulk of the mistakes. And trying to think through what that means for all of us is part of what I had been trying to do, especially in the stories in this section. The second section, and the second reason behind the imperfection of medicine, is about how much mystery still remains in the human condition, how much of medical science still remains terra incognita. And so in one chapter, I consider not rare problems, but very common problems like...
Really indebted for the way in which Atul Gawande has translated some of the more technical everyday concerns of a physician into language that we lay people can understand. And I know that all of us wish that more physicians could do that. Thank you very much for coming tonight.
Thank you. Well, thank you, everybody, for coming out, and it's a special event for me to be here in Washington. My wife is from Alexandria, Virginia, and over many years I've had a lot of time spent down here. And then I did have the special opportunity, now almost embarrassingly 10 years ago, to work in the Clinton administration on healthcare policy and spend a wonderful more than year and a half, and also at times difficult time during that period. Well, I went on to medical school and my medical training and into surgery of all things. And about 4 years ago, I found myself in the odd and wonderful position of getting to write occasional essays about medicine and science for the New Yorker magazine. About 2 years into it, I was approached by a publisher with the very flattering idea of trying to put together my ideas about how medicine worked together for a book. And I said, of course, why I'd love to. And now this, I'm both nervous and proud to say, is the result. I'm, as I mentioned, still a young doctor, a surgical resident, nearing the end of my 8 years in training in surgery. And this book arises out of the intensity of that experience. I've come to think of medicine as a strange and remarkable and also sometimes disturbing business. And writing became my way of thinking through what it is